Hello, my name is Holly Tanner with the Herman and Wallace Pelvic Rehab Institute, and I'm here with longtime faculty member Lila Abbatte. She is a clinic owner. She is faculty at universities. She has taught in our course series since the Institute started, and she has also written specific courses for the Institute that expand upon specific topics. One of those is the course all about the coccyx, and another is a specific bowel course. Lila, is there anything else you'd like folks to know about you in terms of your background and your clinical passions?
Hi, Holly. Thanks for having me. So I've been a therapist for 25 years, and one of my passions is, of course, treating just pelvic pain in general, but I have a subspecialty of bowel and coccyx pain. When I'm looking at some of my patients in general, I've treated pediatrics, I've done a lot of integumentary work, I've worked as faculty, as you had mentioned. So I'm kind of like able to think about the whole entire lifespan. And even as we age, the colon starts to move a little bit slower. So I just find all of these different types of patients and as well as different ages and how that affects the colon. So that's kind of how the course is somewhat put together. Not so much focusing on pediatrics, but just like the differences of them. I have taken Dawn's course and she's taken mine. And it was very interesting that she says, wow, you treat adults really differently than you treat pediatrics. And I'm like, agreed, because I was taking her course and I could agree with that. It's nice to have both courses if you do treat all ages in bowel dysfunction.
And back when you were developing this course, you really had a lot of interesting and different threads to pull in when it came to bowel health. And so one of the things that I've heard you say is it isn't just about the muscle function, which of course we're so well qualified to be evaluating and training. What
Right.
are some of these other big pieces of the puzzle that you think are so valuable to pull into that care?
Yeah, so when we were thinking about bowel function, and when we learned it, the basics in 2A, looking at colon motility and constipation, what's considered constipation, what's considered fecal incontinence, besides the obvious, it's this idea of urge that really is of the most importance. And, it's sometimes we're not asking our patients or even understanding what's the physiological effect of the colon and when does the patient know when to sit on the toilet. And a lot of times you would think that that's common sense. Oh yeah, I get an urge, but sometimes people just feel like rumbling in their stomach and they're sitting on the toilet like a half an hour too early. So when patients are in that state for a really long time, whether it's bowel frequency and they're on the toilet too often and or constipated that they're sitting too long on the toilet, they're in these patterns for years and they forget what normal is. The idea of educating the patient on what normal should be is essential. And so I took a Janet Hume course and she talked a little bit about bowel dysfunction as well. And she says, we don't really talk to our patients and tell them exactly when they're supposed to push or what it should sound like. But she's like, you're supposed to sit on the toilet and just like push and breathe. And that should be enough to get your bowel movement out. And sometimes when I'm saying that to a patient, they're like, oh my gosh, I struggle. I struggle desperately. People are thinking I'm dying in the bathroom. And so it's that idea of understanding urge, when they should sit on the toilet, adding in the ideas of food and competing products that they can find on the counters at the drugstore. Sometimes they're taking something that's softening their stool along with something that's bulking their stool, and the patients just don't know the difference. We talked briefly about microbiome. We talk a little bit about stool testing and companies that do that for patients. We talk a little bit about food. So there's a little snippet of all the little topics. And then I talk a lot about biofeedback. I have some videos on biofeedback, normalized closing and opening, and what it should look like with your biofeedback if you have one that connects to a laptop. So I think that's also important.
Mhm. And what are some of the sort of the skills that someone would expect to walk away from this class with? Certainly a lot of knowledge, a lot of integration of research and clinical application, and probably a lot of clinical reasoning, I would suspect,
Right,
with the
right.
class you teach. What other
Yeah,
skills might
no,
someone understand?
bowel dysfunction becomes really interesting to a lot of people. They love the detective work that goes into it. Bowel diaries are really interesting to read. People typically are creatures of habit. They're probably eating things that are bothersome to them on a regular basis and not even realizing until it's brought to their attention. Understanding how much water is needed. And sometimes it's actually so little in order to create good bowel motility. But most patients are dehydrated. They don't realize the idea of changing colon transit time, how the colon will easily adapt to a massage and or even using a TENS unit or something that will help move stool around different points on the body, different areas on their elbow or at their knee that can help create bowel motility. So we have like all of these little tips and yoga moves that help with that as well.
Mhm. And what got you so passionate about bowel function?
I don't know. I took a pelvic floor one course and I was fascinated, great. And then I said, let me find a class that I can keep my pants on. And so I found a biofeedback course and it was about chronic constipation and pain. And so then here I am putting a sensor in my rectum, so slightly different. But nonetheless, it was 2 days of talking about chronic constipation and pain. And sometimes patients do have rectal pain when they're going to the bathroom, so they can go together. And I just became fascinated with the topic. Then I had a mentor who was one of the teaching assistants in that course because I just really loved her energy and I was able to jive with a lot of things that she was saying. And then I worked with her for 2 years. So what was interesting about her, which is Elise Stetner, she was not really a manual therapist. So she really didn't like palpating patients. She just really used a lot of biofeedback. So I became very proficient in the use of biofeedback. And then from there, because then I went on and I took pelvic floor 2A, I was like, oh, this is where the manual part comes in. So then I was able to combine the two loves of manual and biofeedback with all of the pelvic patients. And pelvic patients can be kind of complicated. There's a lot of factors. They can become obsessed with making bowel movements. They can relate their whole entire lives around toileting. So it becomes a little overwhelming for them and their family members. So I also like that social emotional component that went with it and help them get past those points.
That's awesome. Is there a success story you love to share with people? I always think about this young woman I worked with who would literally have a bowel movement about every 3 weeks. And she would describe passing out from straining on the toilet, having to take all this pharmacology the day prior when she started feeling things were going. And, it only took about 6 to 8 weeks to get her to have a daily pain-free bowel movement.
Right.
You have stories like that as well?
Yeah, I mean, of course, I think that some of them are so incredibly touching as well because they're so appreciative. Like one woman came in, she's just like crying on her evaluation. I want you to save me from getting a colostomy. That's exactly where I'm heading. So please, 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 is there anything that you can do for me? So now she was not my old pelvic patient, but she was an old pelvic floor patient on Elavil for many, many years. And she had tardive dyskinesia, which are the involuntary movements. So she had, a flailing of her arm every so often and or her leg from being on Elavil for her dyspareunia. And so then I was like thinking, is that like relating to her bowel function or dysfunction? And I had her do a bowel diary and she's like, oh, come on, do I really have to do this? And I'm like, just entertain me, please, please do it. And she drank 1 drink a day. That was all. She had 20 ounces of water. And then she had about 32 ounces of coffee every day. So she was severely dehydrated. And we just worked on increasing her water intake, some of her muscle function, but she had already gotten Botox and seen a few other pelvic PTs. And like that was quick. Within a month, she was pooping and that wasn't a problem. So like sometimes it's like that simple and you wouldn't think. And she's about to get a colostomy. That was her appointment that she had set up next.
Right.
And
And that is such a lifestyle change, In this class, speaking of colostomies, then, do you also get to share some stories or talk about those patients who perhaps are doing a colostomy reversal and what that might look like?
right. It's a short touched on thing. We talk a little bit about colostomy reversal. We talk a little bit about J pouches. We talk about even mesh in the abdomen because sometimes that can affect bowel motility. We talk about bowel frequency. A lot of patients who've had colon resections have bowel frequency and how to retrain the colon, similar to how you would retrain the bladder.
Mhm. Excellent. Well, is there anything else you'd like folks to know about the class in terms of why they should come on in and enjoy the coursework?
I think that when you're starting to see that you're having a lot of patients on your schedule that do have these complicated bowel motility issues, it's nice to have a better understanding of what the stomach is supposed to be doing, where the sphincters are, how you can assess them from a myofascial standpoint, looking at, of course, large intestines and some other issues that would come along with myofascially treating them. And understanding bowel movement urge and the physiology, I feel like that's a real important component because a lot of patients do have slow colon transit time. And looking at medical tests that they've had done, understanding where they are within their over-the-counter products and or prescription medications, and how, with the permission of the referring physician, we can wean them down off of maybe some of the medications and move them up, titrate them up on some over-the-counter products, and pretty much change their lives. Pooping is not so obsessive anymore. Yeah.
Right. Well, and I know you're also really passionate about helping, especially younger clinicians or newer folks to pelvic rehab, understanding that clinical progression, right?
Mhm.
Folks might know what questions they want to ask or how to do some evaluation, but that progression, well, what if you're 4 or 5 sessions in? And don't you often find this is true? People will say, I've seen this person for 4 weeks now, and they're only 40% better. And you're thinking, that's amazing. But a
Right.
lot of clinicians almost want to give up, or they feel that it should be happening faster, or they don't quite know which things to try next. And I know you're real
Yeah.
passionate about that.
And Stacy Futterman, she was actually my instructor for 2A, and she was always saying, listen, the colon is a really slow learner. And that's very accurate. Colon doesn't like change. If you're seeing a 40% change within a month, that's outstanding. And so sometimes we have to be a little bit more patient, and then also educate our patients on being more patient with themselves.
Mm.
They think that everyone wants the magic pill, no doubt, with any condition that we have. But nonetheless, sometimes we have to look back about 12 weeks to 16 weeks later and say, oh, do you remember? These were your complaints. And I think that's one of the more important things to write down also with bowel patients. As soon as they come in, what is their specific list of complaints? And sometimes I'm writing 8 different things. How long are you sitting on the toilet? How many times are you on and off the toilet? Do you actually go to the bathroom? Do you get an urge? And reinstating normalized urge is probably the first goal. And then looking at all of these complaints, and then you're looking back 12 weeks later and you're like, okay, so we can get rid of this, this, and this. Don't you feel better about that? And like, a lot of people are like, oh yeah, I've come so far. And I think the most important thing in bowel function is to reassess their goals, because initially she's crying about her colostomy bag, that patient. And then when we now get to that point where she's pooping every day, now I have stomach pain. What do I do now? Well, you're on 290 milligrams of Linzess. So maybe we can start to move that down. And that's a conversation with her referring physician. So you're reanalyzing their goals, which is what we're always doing, assessing and reassessing, but making sure that we do that with the bowel patients, because they always want to be normal. They don't want to think about their pooping. And so then where are they? And understanding what they need.
Excellent. Well, Lila, this is a really well-received class. Everyone gets so excited and feels like they pick up so many clinical pearls. And so thanks for sharing some information about the class. And I know that it's offered at least a couple times every year.
Yeah,
And
I think we moved it to like almost once every 6 or 8 weeks or so.
brilliant. So
Yeah.
people will have an easy time getting into the class. And thanks again for sharing all your knowledge and experiences.
Great. Thanks for having me.